Hi guys, my name is Yazan. I'm just going to take that out. Yeah, good. So yeah, my name is Yazan. I'm one of the founders of QuestMed and also currently an internal medicine trainee. So I'm working at St. Thomas's Hospital at the moment in the intensive care unit, and I was at St. George's last year, so generally in South London. This is the second case that we're running through, which we did last time. We sort of ran through a case and talked about the ins and outs of how to approach patients from a diagnostic sense, investigations and management. And the aim is to develop your clinical reasoning and your understanding of cases and to sort of push you forward in your path to become a doctor. And it's mainly sort of aimed at sort of penultimate years and final years as well, as a sort of slightly more advanced, but obviously anyone can join in and learn. And what I would suggest for you during the session is to just have a pen and a paper at hand, because there will be some things where I sort of ask you to write down your problem list or your management plan, which is the same that you might expect, for example, when you're working in a post-take ward round, for example, or you're in an acute medical clinic. So please make sure to have a pen and paper to hand. I think we'll start, and any questions we'll deal with at the end, if that's okay. Or if it's really sort of important or burning, then I'll answer them during the session, but feel free to put them in the Q&A in the meantime. Cool. So QuestMed, as a lot of you know, so it's a question bank. A lot of our questions normally try and make you think and try and help you to think about the situation, clinical scenario laterally. And this is sort of an extension of this, trying to take this idea that you need to think like a doctor and think how to deal with a patient as a whole. And then this integrated clinical case hopefully will take that a step forward to a more practical perspective as well. Our mobile app is about to be released in the next, I hope, in the next 10 to 12 days. And at the same time, we're going to add another 2,000 questions. So our total number of questions will be 6,000, which we're very, very excited about. That's very soon indeed. So let's talk about our patient. So we have Morgan, who is 83. He was watering plants in the garden. He fell on his right side, and he doesn't remember anything that happened, which is all a blur. But he didn't lose consciousness. He wasn't groggy, but he has some pain in his right arm and doesn't know any of his meds. And here we begin to realize the issues with patients that don't do what you want them to. They don't tell you what happened before the fall, during the fall, and after the fall, which is normally what you should be asking in terms of any sort of features that have come before, because it helps you to sort of localize what the cause is. But in this case, he doesn't know. And also he doesn't know any of his medications, which is not helpful. However, he does know a few. He has a metallic valve on warfarin, and his INR is normally 3.5. As you know, if you have a metallic valve, you should normally have an INR of 3 to 4. Anyone who is on warfarin, they usually have this sort of yellow book, and they put in all their INRs, and it gets seen by the anticoagulation clinic. So anyone who's on warfarin, always you need to ask them, do you have your yellow book? Can I see it? That's a good thing, especially in OSCEs, to show that you know what these patients, what the impact of this condition is on their life and how they have to get monitored in warfarin. And that will help you to understand the decisions around anticoagulation. He's on insulin. He's got CKD stage 3. He has rheumatoid arthritis, high blood pressure, hypertension, and he has actually had a recent fracture after a fall. He lives with his wife, who is independent but actually quite frail, second floor flat. Daughter's a paramedic, doesn't smoke. He's normally independent and drinks socially on weekends. And he is comfortable at rest. He looks a bit tired. He has some ulnar deviation. He has a midline stenotomy scar, fine, as you expect from a metallic valve replacement. And then here you can see the heart sounds 1, 2, and 0. In someone with a metallic mitral valve, you would expect S1, so the first sound to be loudest and metallic sounding, whereas if it was an aortic valve, you expect S2 to be loudest. His JVP is not raised, but he does have some peripheral edema, which is interesting because, as you know, the cause of peripheral edema can be quite a large number. So normally you would think of things like heart failure, you'd think of things like liver failure or renal failure. In his case, his JVP is not raised, he's comfortable at rest, less likely to be heart failure. He doesn't really have any known liver failure, and he's got CKD stage 3. That would not normally be so significant in terms of renal failure causing peripheral edema. So the most likely cause, if you were to just think about it in your head, is probably going to be perhaps one of his medications. So he's got high blood pressure, so it could be amlodipine, which is very well known to cause peripheral edema. And he's got loads of pain on abducting his right arm. Okay, so that's the case. And then, so what I'd like you all to do is to please make a problem list and make a plan. And I'd like you to actually write it down because that is the best way to remember stuff. So feel free to do that. I'll give you 2 minutes. And if you have any questions or anything, just let me know. So I guess we also are a small enough group, I suppose. So if you want to put stuff in the chat and you want to sort of interact in that sense, then feel free to. If you have any sort of problems that you think, you think important, and also if the aspects of the plan that I really shouldn't miss. So. Okay, cool. So almost done. So another 20 seconds or so. Okay, cool. Right, so let's crack on. You guys have, I hope you have written it down. Trust me, it is more important for you because you'll end up learning and you'll end up comparing against your own plan. Good. So the plan is going to be sort of, the problem list is going to be short to a certain extent because we don't have all the information. We don't have our investigations yet, okay? So, so the initial problem list is actually fine. Like it's not that sort of challenging. So it's fall, query cause, pain, query fracture, and query able to cope at home, which I think is fair because, you know, you have someone who had this quick, relatively sort of short-lasting episode where he fell, he woke up and he was fine, he's got some arm pain, and I suppose the other thing is that he has had a previous fracture and he lives in a second floor flat, and also his wife is with him but is a bit frail. Is he going to be able to cope at home? Those are the initial problem lists. But I think what we do tend to do in the acute medical take is that when you have a problem list, you do some more investigations and then you sort of update the problem list. So we'll do that later as well. So that should hopefully be useful. So keep that in mind. So normally what we do is whenever in a Viva or when you finals or whichever exam that you're doing, it's always good to sort of do things according to a system. So I always think to myself sort of bedside, bloods, imaging, and then invasive. That's the sort of thought process I have in my head. So in this context, you should be doing a full set of observations, looking for any sort of tachycardia, bradycardia, if there's any hypotension. Blood glucose is useful. He's on insulin. That can cause hypoglycemia. The ECG will help you with cardiac causes. The urine dip, because UTIs, urinary tract infections, can be very common in the elderly. Lying and standing blood pressure, because postural hypotension is a very common cause of falling in the elderly. And in lots of institutions, particularly lots of geriatric departments, they do like you to do rectal examinations, even for people who don't have any rectal rectal features or any sort of change in the bowel habits or whatever. And one of the reasons for that is people who are constipated are more likely to fall. And so depending on where you work, on how the index of suspicion, you may also want to do a rectal examination in this group of patients, but I just put it in brackets here. Full blood counts for anemia and signs of infection, inflammation, urea electrolytes for any sign of renal failure, CRP again for inflammation, troponin for any cardiac issues, HbA1c for diabetes. And you could also consider doing a BNP, looking for any evidence of heart failure, although in this context, it's got some peripheral edema. Maybe it might be useful, but probably you would want to do an echo anyways in this scenario, maybe as an outpatient. So you could do either. He's on anticoagulation, he's on warfarin. So to be honest, anyone with a fall, it's probably better to do a CT head for them because if they're on warfarin, it's a higher risk of bleeding. Chest x-ray is useful, looking for any evidence of a pneumonia, for example, or fluid overload. Right shoulder x-ray because he's got pain. And then the echo and the 24-hour tape, those are sort of cardiac investigations we would consider as causes of a fall. So echo, you might have someone with, a valvular lesion that can cause syncope or collapse, but also you can have an arrhythmia, and that's why you would do a 24 to 48-hour tape. And again, just for completion's sake, sometimes you do bladder scans because elderly men can sometimes have bladder outflow obstruction. So the other general stuff you would do in terms of management is you would admit the patient normally for monitoring, especially because they are not probably unable to look after themselves at home. And then you would treat them with fluids. If they're a bit dehydrated, I think he seemed a bit tired. There wasn't really that much evidence of dehydration, but I think it's probably reasonable to consider it. And then analgesia, and then PTOT, which is physiotherapy, occupational therapy. They may need a few carers, for example, just to get them over this few days because they can't look after themselves. Cool. Any questions, let me know in the chat as well. So I think the first issue that I wanted to discuss was the concept of the comprehensive geriatric assessment when someone has a fall. And realistically, you should really be looking at the patient as a whole and trying to figure out what the cause of their fall is. And only then can you say that there's no sort of obvious fall. I'll get to that obvious cause, which I'll get to that later. So there are, the first thing you should ask is whether or not there are any complications of falling. So if someone's got a head injury or a soft tissue injury or a musculoskeletal injury, and just going from the top, issues with, so if it's a neurological cause, so seizure, stroke doesn't usually cause syncope, unless it's like a posterior stroke that can be secondary to sort of cranial nerves or affecting sort of blood pressure and things like that, but less likely. And then eyes and ears, so people can fall because they don't have their glasses on, or they don't have again, if they don't hear the dog and they don't have their hearing aids in, for example. And heart can be divided into muscles, electrics, and valves, so it'd be useful to check the ECG and troponin, and electrics, ECG, and 24-hour tape, and valve would be useful to do an echocardiogram. GU, we talked about urinary retention. Dehydration is very common, very important in the elderly. And then in the lung, looking for any evidence of infection or pleural effusion, constipation, and then peripheral neuropathy is useful in patients who, to look for in patients who have diabetes. And finally, to sort of complete everything, it's reasonable to look at their footwear to see if that can be improved, as definitely can be a cause of falls. And finally, I think one thing that we don't consider too often is that if someone has worsening of a chronic medical condition, that can also lead to increased risk of falls. So someone with Parkinson's who's not very well controlled, someone with dementia who has worsening dementia, that can increase the risk of falls. So that's sort of how to think about patients as a whole coming with a fall, especially the elderly. So you look at this patient and then you look at the x-ray, and then it shows this. So I don't know if you guys want to, in the chat, tell me what you think. Do you see anything exciting there? Let's see what people think. And also if you have any management for it or any sort of thoughts about the management. Let's get a bit, yeah. So someone said a fracture, that's fine. Yeah, cool, I agree. I think there was a fracture. So there is certainly a fracture. So what you can see here, I don't know if you can see my mouse, so you can see this like sticky out thing. As you can see, I'm not an orthopedic surgeon, but yeah, generally the idea is that you should really always try and track the lines together. So the lines, and see if there's any change in the line, and there is here, and you can see that there is a humeral head fracture. And I guess, again, not an orthopedic surgeon, but I know a bit enough to get by in this scenario. The question is sort of what you would do. And on the most part, the stuff you would do is usually conservative. So you sort of put people in a sling and you rehab, and then sort of physiotherapy, occupational therapy, etc. But it's quite important to check the neurovascular status of the patient. So if you know which nerve can be affected, please put it in the chat and let me know if you know. But realistically, what you need to do is to just check the nerves. So check the sensation, check the movement, and also to check the pulses as well. So it's very useful. Good. So yeah, so people are correct. So the axillary nerve is correct. That is something that can affect the sensory changes in the that can lead to sensory changes in the sort of, as someone has just said, regimental patch area, which is on the shoulder, and it's where the sort of badge is normally, technically speaking, and that's the axillary nerve and what can affect. So it's good to just check that as well when someone has a fracture, a humeral head fracture. Cool. Fine. So, okay, what additional medication should this patient be on given the fracture? Does anyone know? So this is sort of, yeah, someone is saying, okay, what have we got? We've got bisphosphonates, got low molecular weight heparin. Okay, I'm going to agree with bisphosphonates. Analgesia, yeah, good. Analgesia is very important. I think we said analgesia, but yeah, bone protection definitely. So that's sort of what I'm getting at. I think, yeah, we're all roughly on the same page, which is fine. So basically, there are lots of reasons that this patient should be on bone protection. I just wanted to run through that briefly so we're all on the same page in that sense. So osteoporosis is a very important issue because it can increase your risk of fractures and disability, and especially if you have a fracture such as a neck and femur fracture, that is associated with a high risk of morbidity and mortality. So really, you really want to try and prevent that whenever possible. So the risk factors, as I've put out here, if someone's on steroids or they have hypothyroidism, alcohol, if they're quite thin, low testosterone, there's quite a lot, as you can see here. In our patient, we actually have quite a few. So we don't know if he's on steroids. He might be because of his rheumatoid arthritis. But actually, even rheumatoid arthritis in itself is a risk factor. Also, what else has he got? He's got renal failure. That's a risk factor as well. But I think that's it really. But he's got a few, enough for us to be concerned. How would you manage osteoporosis? So essentially, you would normally when you're thinking about sort of vibers, you'd say sort of conservative, medical, surgical. In this scenario, there's no surgical really, apart from if they have a fracture. So the conservative is going to be stopping smoking, exercise, and limiting alcohol. Medical is going to be vitamin D replacements, essentially everyone, because not many people are exposed to sunlight in the UK. And then the first line treatment is often going to be bisphosphonates, and they give that weekly. Basically, when you start someone on bisphosphonates, they need to be able to sit up for 30 minutes after because there's a risk of esophageal irritation. It's also associated with osteonecrosis of the jaw, so it's useful to get a dental assessment as well. And then there are other treatments, which I don't really want to go through in too much detail. I discussed this in one of my previous lectures. I think it was the geriatric lecture I gave. So yeah, just for reference, just the other stuff that we can give as well. But certainly bisphosphonates is first line. Yeah, the other thing you need to tell patients about is that it can sometimes cause a lot of sort of gastrointestinal irritation. So just when you're consenting patients for it. Good. So that's osteoporosis. All right, so your results of the investigations are back. You have someone who has had no postural drop, which is good. His glucose is 6, ECG's NAD, so nothing really there. Urine dip, normal. HB is 120, platelets 180, urine electrolytes normal. CRP is 10. Troponin is 30. The question here I pose is, what would you do next? Would you be very concerned about the cardiology? Would you be calling the cardiology SPR, the registrar, saying, oh, I think this man has had an MI? And the answer is no, you wouldn't. What you would do next is you have you would essentially check the troponin again. So you sort of do it in a few hours and see if there's any change, because troponin can be raised for other reasons. So patients who have renal failure, for example, so this chap has CKD, that could be raised as well. Normally troponin is sort of like 10, 15, maybe about 10. So it is high, but it's not sort of hugely high. So sometimes in patients with very severe myocardial infarction can go up to the thousands. But again, if someone is sort of 40, 50, it's good to just check it again just to make sure. BNP isn't back. It does take a few days normally. CTI is normal. You've got a chest x-ray shows a pleural effusion, which is present on previous imagery and known to the respiratory team. Does anyone know why he might have a pleural effusion? If you can put on the chat. So someone said chronic heart failure, which I take. So definitely chronic heart failure is a cause normally of bilateral pleural effusion, but it can definitely be caused by, you can have unilateral pleural effusion second to heart failure, but certainly it's more common to be bilateral. In this scenario, it was because of his rheumatoid arthritis. So the rheumatoid arthritis is a cause of pleurisy, so it can cause some inflammation, and subsequently you can have pleural effusions. In this particular scenario, it's probably related to his rheumatoid arthritis, but certainly heart failure can be the case. The echocardiogram was normal and there were no arrhythmias. Cool, so that's him in terms of the investigations. So if we were to update our impression, we would say that this gentleman has had a fall with no obvious cause. In some instances, you could say that this patient has had a mechanical fall, although technically speaking, geriatric doctors don't like the use of that term, so I wouldn't normally say mechanical fall. I think I just put this chap not having obvious cause just to show you the breadth of the geriatric sort of assessment and how the stuff that we use, how we sort of do quite broad investigations, which is normally what sort of stuff comes up in your exams, like quite broad things, and the breadth of the investigations that we do. So he has a right humeral fracture, he's unable to cope at home, requiring PT-OT assessment. So that's fine. So that's him to start off with on the first day of his admission. So he is admitted and he's feeling better. OT, he needs some carers, working with physio, ward ground is good. You take a trip to C ward, which is what my registrar always called coffee. So no one knows we're going for coffee. And then everyone goes to teaching. You check the bloods at 4:55 p.m. just before you're about to leave. And then you find this. And you really weren't prepared for this. This is very stressful. You're an F1. There's no reg. There's no SHO. What would you do next? So then I'll just give you a minute to think about the plan. So how would you go ahead with this gentleman? Let's see. Let me go back and sorry, so you know what actually. Cool. So this is very much the stuff that you might get in sort of, and if you're in final year sort of interviews, like AFP interviews and things like that. These are the sort of thought processes that you should be having about managing patients as a whole as well. So hopefully that's useful as well for those who are preparing. Cool. All right, so let's move forward and talk about what the plan is. So the key issue, I suppose, that you're really worried about is the potassium, isn't it? That's the 6.2. So normally you'd want it to be sort of, you know, more than 5.5 is considered high, more than 6 tends to be something that you would consider treating. So let's just talk about hyperkalemia. The causes are many. In this particular scenario, because of the raised urinary creatinine, you'd expect this to be related to an acute kidney injury, and that can be secondary to lots of things. Possibly you can get it in patients who have had fractures, you can get it in patients who are dehydrated, not eating very well, and also can be exacerbated by things like ACE inhibitors. Spironolactone can cause hyperkalemia, and as you can see, there are other causes. Rhabdomyolysis tends to be secondary to muscle breakdown and severe trauma. In this particular scenario, you wouldn't really expect it to be the case because he hasn't had a huge amount of trauma. And patients who are on digoxin can cause hyperkalemia. However, digoxin toxicity in itself can be precipitated by hypokalemia in itself. So the key thing you should be doing in the first instance is going to be to try and get an ECG, because that will help you to see whether or not there's tall tinted T waves. And as you can see, the more severe the hyperkalemia, the more stuff you get on the ECG, and it can range from tall tinted T waves, and it can range to sort of ventricular fibrillation, asystole, and cardiac arrest. So it can be pretty bad. So you have to sort of act relatively quickly. So first thing you should do is to check the patient, ABCDE approach, make sure that they're stable. If they have any chest pain, any palpitations, any shortness of breath, and then do an ECG, and then subsequently it'd be useful to repeat the blood test and also treat the hyperkalemia as well. So we will talk about that. So if there are ECG changes, would you then give a calcium gluconate? And the idea is to try and sort of reduce the effect of the potassium on the heart and protect the heart. You usually give that over 10 minutes. And then what you can do is insulin and glucose. Insulin to put potassium back into the cells and glucose to prevent a hypoglycemia. Other stuff you can do is give salbutamol, because that does a similar sort of thing. It pushes potassium into cells, and also sodium bicarbonate. A lot of the time we give that if someone has an acidosis rather than just on its own. And then the other stuff you can give later on, sort of dietary stuff, stopping ACE inhibitors and spironolactone is very useful, and then treating the underlying cause. And then dialysis, which we'll talk about in a second. So the other thing is about the hemoglobin. So if you go all the way back, you'll find that randomly the hemoglobin is 69. And that sort of is something that you really didn't expect, and it doesn't really sort of make sense that much in the context of the hyperkalemia and the acute kidney injury. It's probably unrelated, but I guess the question is, how would you manage that? You may have sort of documented it in your management plan when I gave you a minute earlier. So realistically, what you should be doing is to sort of, in the acute sense, again, the same thing in your ABCD approach, ask the patient how they are if they're symptomatic. But on the most part, if someone's got an HB of less than 70, we would tend to transfuse. And normally sort of 1 unit is equivalent to an increase of 10 gram per liter. So then in this case, 2 units is probably reasonable to get up to 90. That should help in terms of making him feel better. But then the next question, in anyone who has a low hemoglobin, particularly someone who's got like a microcytic anemia, especially iron deficient, you should really be considering whether or not they need a PR, whether or not they need a OGD, so an endoscopy. And then I guess in this context, just I was thinking about it earlier, that if someone has got some bleeding somewhere we don't know, it's probably reasonable to get the orthopedic team to see him to see whether or not there's any bleeding into the joint in itself, as that may sort of have a change to management. But also just sort of a thought process that we normally have on the wards for the most part, to think broadly about the topic. Cool. So that's that. So yeah. So you do that. You give the insulin dextrose, and you actually try a few times. You give insulin dextrose, but then the potassium keeps rising. It goes up to 7, and then you're a bit sort of you're not sure what to do. So what should you do next? Does anyone know what the next step is in this particular scenario? See what people think. Cool. Yeah. People are talking about dialysis, which is good. So that is the correct answer. So we should really be thinking about dialysis. Actually, sodium bicarbonate is probably a reasonable bet in someone, but yeah, definitely dialysis is a good shout. Cool. So and actually, as someone was saying, normally the dialysis doesn't really happen on the ward. It normally happens on the intensive care unit. Sometimes renal can do it, on renal wards as well. And then it really depends on the hospital, realistically. But I think in severe sort of in the sort of from a medical perspective, normally they go to IT, in my hospital at least. But yeah, depends. So there are certain indications for dialysis. So acidosis, so usually sort of the pH is less than 7.35. And electro abnormalities, and mainly is sort of refractory hyperkalemia. Refractory is key here, so not anyone with hyperkalemia needs to go to dialysis. It's the ones that keep coming back, or it's not really working with our treatments. And if someone has like a toxin-related AKI, so if they had an overdose of some sort, that is an indication for it. If you have really bad fluid overload and pulmonary edema, definitely an indication. And if you have very high urea, that can cause, that is essentially a very, very high urea that precipitates encephalopathy or pericarditis. And I've seen some instances where very, very high urea on its own is an indication for dialysis, but I think on the most part you'd want to sort of see evidence of a complication like encephalopathy or pericarditis or something like that. But I think that depends on the consultant. But as a mnemonic, I think it works quite well. Fine. So yeah, I think there's just as a point to make, you're not really expected to know that much as a medical student about dialysis. There's two different types that we normally give. Hemodialysis works by diffusion of solutes, whereas hemofiltration removes solutes by convection. And it's a sort of a trivial point, possibly from a pathophysiology perspective, especially for those who don't do it every day. But I think the main difference is that in the acute setting, we normally do hemofiltration, whereas in the sort of chronic dialysis setting, we do hemodialysis. And then the key thing about it is that you're trying to sort of flush out all the toxins, and you have a semi-permeable membrane, and stuff moves across and trying to filter it out, and it goes back into the patient. That's roughly how it works. And you can use there are a number of ways to do your dialysis, which I'll talk about in a second. And yeah, you don't really have to know that much about it unless you're a bit more specialist or working in an IT or a renal unit. So I suppose you will have heard a lot about fistulas, so arteriovenous fistulas, which is the picture that I have on the right here. It is a very it's a prolonged process. It's a thing that takes ages to get ready. So obviously in the acute setting, you can't really put a fistula in. It's someone who sort of has end-stage renal failure, and you're preparing them for dialysis, and it's an elective surgery, and then it sort of connects an artery and a vein in order to allow for blood to flow through. In the acute setting, what we normally do is we put in a fast cath, which is a sort of central line that goes into the heart, or into the where it can go into multiple places, but on the most part, it tends to go into the internal jugular, and that allows us to achieve dialysis very, very quickly. So when you see patients who have had dialysis in the past via VASCATH, you may sometimes be able to see some scars there, which I'll talk about in a bit more detail. I'll talk a bit more about some fistulas and stuff shortly. And I guess with hemodialysis, the complications, just generally speaking, not for the acute setting, is that alongside end-stage renal failure, one of the key complications is cardiovascular disease and associated complications, such as myocardial infarction. You can have fistula complications, so you can have stenosis of the fistula, you can get aneurysms, you can get infection, and you can get some ischemia where there's sort of reduced perfusion into the limbs, so therefore you get ischemia of the arms, which is something to look into. So to look at when you're assessing someone with a fistula. Hypotension. Chronic dialysis can lead to amyloidosis, to build up this B2 microglobulin protein. And then finally, in some cases, you can get dialysis disequilibrium syndrome, which essentially lots of fluid shifts can lead to acute cerebral edema, but that's a bit small print. I think the key thing to know about dialysis is the cardiovascular disease, the fistula, and sort of the fluid shifts that can cause hypotension. Those are the main ones. The rest is sort of a bit SBA stuff. Cool. So he got an improvement with dialysis. He stays off dialysis. He gets stepped down to the medical ward. All is well. You've treated him, and he goes home with a package of care. He's fine. No big issues on your end. So you've done very well. So you see him in the clinic a year later, and then you do a few blood tests, see how he's going. His HB is very high. His blood glucose is 14, and then his urea is 9, creatinine is 160, and he hasn't really been seeing his GP in the past few months. So I guess this is sort of now in more OSCE mode. So the question is, how would you approach this from a history and an examination perspective? So I'll give you just 2 minutes to sort of think about it and go through, and then we'll regroup. And really, this is more about sort of how would you talk about his diabetes in the context of worsening renal dysfunction. That is the thought process. Cool. Right. So let's move on and see what people think. So again, this is talking about diabetes and talking about how you would approach these sort of OSCEs, which are quite common in sort of penultimate year and final year OSCEs, to be honest. I think I had, in my finals, I had an OSCE scenario that was like this, but it was more of a sort of type 1 diabetic, didn't want to take his insulin. You know, how would you approach this? And how do you sort of talk through the diabetic check, which is it's quite a juicy topic that you can talk about. And the actual medical knowledge is not a lot. It's more about sort of having a systematic approach to things. So let's talk about it. So basically, the key things you need to ask about in this scenario is sort of, you know, obviously the type of diabetes, and really, do they actually do stuff towards the diabetes? Do they check their capillary glucose? Do they take insulin? Are they compliant with it? And the key is, are any reason that they're non-compliant with it? Do they have any admissions? Have they had admissions in the past with DKA or sort of HHS? So that should read HHS rather than HSS. So that's sort of hyperosmotic or non-ketotic syndrome, where you get this very high glucose and sometimes acidosis, but without any ketones, and it's more common in type 2 diabetics. The question is, any hypoglycemia? Do they drive? Because in patients who have insulin, they have a lot of restrictions on driving, and really compliance is the main one. And this particular scenario, it could be that he just doesn't want to take his insulin for whatever reason. I think in my patient who had type 1 diabetes, people would make fun of him and called him sort of a robot or something because he took the insulin or whatever it was. So it's just sort of trying to look into the patient's ideas, concerns, and expectations. And then asking about things like complications, so stroke, MI, eyes, kidneys, and those can be asked by sort of visual problems, or if they're having any sorts of falls, because that is associated with neuropathy, and whether or not they have any sort of claudication, so if they have any pain in their legs, for example. And it's important in diabetes and any of these sort of patients is to look at other cardiovascular risk factors: smoking, diet, weight, cholesterol, and blood pressure. That shows that you have a good understanding of how diabetes can affect the whole body. The next thing is about just examination, because sometimes you can have stations or situations where you just ask to examine. And a good way of doing it is to just start generally. So BMI, urine dip is useful to look, because in diabetes you can get sort of worsening nephropathy, where you can get protein in the urine, and that can be treated by ACE inhibitors to try and reduce the amount of renal progression of the renal dysfunction. Lipodystrophy refers to when you have someone who's on subcutaneous insulin. If they keep using the same site, they have this sort of change in the skin, this dimpling. So you can check for that. It tends to be in the stomach, because that's sort of in the abdominal area, because that's where they usually inject. Pulse, blood pressure is useful. High blood pressure is associated with worsening macrovascular and microvascular complications. And then heart sounds would be useful as well, looking for any sort of other cardiovascular risk factors. Xanthal asthma in context of cholesterol. Visual acuity in diabetes is important. Fundoscopy, looking for diabetic retinopathy, and then inspection of the feet. So this is sort of a very easy thing to give you in an OSCE, because everyone has diabetes. Lots of people have diabetes who are sort of and easy to get them to the exam. Inspecting someone's shoes, looking for ulcers, and this concept of a Charcot joint. So basically, patients who have very severe diabetes, sometimes you can get sort of destruction of the joint in itself because of sort of ongoing pressure that people don't really notice. And therefore, you can have a change in the foot itself, and it looks a bit weird. It looks like sort of compressed, and that was a Charcot joint is associated with diabetes. Very different from Charcot-Marie-Tooth disease, which is a cause of peripheral neuropathy. Checking the pulses because of the association with peripheral arterial disease, peripheral vascular disease, and then checking the sensation via a monofilament as well, and also vibration, proprioception, very important to complete your examination. So that's how I would sort of approach this examination, history examination, and that, yeah. So, and then the last thing is, someone asks you how you would manage a patient with chronic diabetes after you've done your history, after you've done your examination. So what would you do next? So let's see. Just have like 10 seconds to think about it, just as we are going across. Maybe write it down if you feel like it. Cool, fine. So managing a patient with chronic diabetes, this is what I would do. So if someone asks you what you do, always say MDT approach. And then again, in this context, conservative, medical, surgical. So conservative is very important to ensure that the patient is educated on the importance of good control. So in an OSCE scenario, you would say something like, if you don't look after yourself, it may lead to further complications. But also it could also lead to sort of renal dysfunction, which you already kind of have. That's something to make it very clear. The question is, does he need insulin? You will not really be expected to decide on whether or not someone needs insulin, but it's important to sort of discuss it, because that can have effect on things like driving, for example, or other stuff. So it's important to sort of mention it. Have you thought about it? If someone is not on insulin anyways. Other risk factors we talked about, whether or not you have regular eye checks, and renal blood tests, very important. Proteinuria, we talked about, ACE inhibitors, and just generally speaking, don't forget to deal with the patient's concerns, because that can bring out a lot of aspects of the communication that they're worried about, and also it can be a sort of starting point for what you want to tell the patient as well. So it does help to sort of help the flow of the OSCE as well. Cool, right. I guess while we're here, I just thought to talk a bit more about some diabetic drugs that we use very often. So normally in someone who is on diabetes, we would start them off on metformin. Key aspects of metformin is that they tend to have GI side effects, such as nausea, sort of abdominal pain, vomiting sometimes. They don't cause hypoglycemia, which is important, whereas the rest of them more or less do. The sitagliptin is usually chosen afterwards. It's reasonably well tolerated, can be associated with hypoglycemia. Pioglitazone is contraindicated in heart failure, previous TK, it can cause all of these and work all of these, and can precipitate TK in some instances. Glycosides can cause hypoglycemia. And then interestingly, just, these are all sort of just smaller points to keep in mind when you're thinking about diabetic drugs, but you won't really be expected to know sort of who actually needs to start them, who needs to increase or have the indications for changing of the medications. Dapagliflozin is a medication that has recently been recognized as very good for diabetes, but also prevents the progression of heart failure. So lots of cardiologists are very interested in these days. Finally, Xenotide, which is a GLP-1 mimetic. Out of interest, it is a subcutaneous injection like insulin. Also, it can help with weight loss sometimes. So just to kind of round up our discussion on diabetes, which is a very commonly assessed and encountered topic in clinical practice. Cool. So last sort of scenario bit, which again is OSCE based. So 2025, you're promoted to renal registrar. There are still socially distant clubs. Mr. Freeman, still alive, doing well, he thinks, but actually he's not really been looking after himself, he tells you. And then you haven't actually looked through his medical history just yet, for example, and you just examine him. Let's just say you've done all that. So this is a bit more about sort of presenting and thinking about differentials and investigations and stuff like that. So what I want you to do is I'll give you about a minute or so and sort of think, or maybe I'll give you a minute and a half, just think about how you would present this patient to a consultant, and also thinking about the differentials and the investigations that you'd have. Those blue lines are all scars. I just sort of put them into, just this is what you would encounter actually in the exam. That's a very weird picture I found on the internet, which is helpful, hopefully. So I'll give you a minute and a half. In the meantime, so there's a mass, someone's asking, there's a mass underneath that scar, which is the right iliac fossa. So if you think you know what's going on, just put it in the chat and we'll see what people think. You could just shout out what you think the scars are, what you think the causes are or differentials are, just to sort of test your knowledge before we sort of talk about the presentation. Right. Okay. So I think that's enough time now. So what's the mass underneath the right iliac fossa? What's that referring to? Probably had a renal transplant. Good. Yeah, I'm happy with that. Could be an inguinal hernia. Wouldn't really expect a mass underneath. Someone said that the AVF is not in use, so the arteriovenous fistula is not in use. That's probably right because there's no thrills or no bruits there, which is cool. What about the scar, which is sort of vertical in the middle? What could that be? We didn't really talk about it today, but it's just part of the whole thing. No nose, fine, okay. And then the scar at the top right, does anyone know what that could be? Yeah, someone says peritoneal dialysis. And then, yeah, peritoneal dialysis definitely most likely there. Good. And then, yeah, could be a AAA scar. Yeah, I'll take that. But it's quite small. A AAA scar usually be expected to be quite big. And then the vas cath, in the top right, more likely to be a vas cath, isn't it? And the finger prick scars could sort of be talking about sort of his diabetes, as it were. Okay, so we have lots of nice ideas and lots of sort of thoughts about what it could be. And I just wanted to sort of show you how I would present this in an exam sort of setting. And what I do it in the way of doing a sort of positive and negative findings, then differentials and management. And then hopefully you'll sort of think, you'll understand how I think about it. We'll talk about it as well. So this is what I say. So I say, I've examined this elderly gentleman. My positive findings in the periphery were finger prick blood glucose testing, an old scar in the left antecubital fossa with no palpable thrill or bluey, and a small scar in the left upper chest. Further examination includes a central scar and a larger scar in the left iliac fossa with an underlying mass that did not move on respiration. And then I talk about the negative findings. No evidence of tremor, Cushingoid appearance, gingival hypertrophy, or fluid overload. And I say, I believe, or the differentials are end-stage renal failure with previous modes of renal replacement therapy, dialysis via central line, peritoneal dialysis, and AVF, and current mode is renal transplant. Most likely causes diabetes because of the finger pricks, and then other differentials are hypertension, chronic glomerulonephritis, and polycystic kidneys. To further investigate, again, bedside observations, fluid balance, urine dip, and then blood tests, and then you can do other stuff as well. So I guess in this scenario, so when I was a final year, I found it very difficult to figure out how to present patients. Do I just say everything I see from the beginning, at the end of the bed, I noticed that there are some shoes, and then there was no clubbing, there were no signs of infective endocarditis. Do I say everything? Eventually I sort of settled on saying positive and negative findings and sort of got to the point. And then you can sort of do it according to sort of periphery and then central. So in this scenario, I say that there's a left antecubital fossa, there's no thrill or bruit. So anyone who has something that looks like a fistula, you should always try and sort of palpate it for a thrill or listen to it for a bruit. And also there's a scar there. The reason I said that the mass did not move on respiration is because, you could have a mass that could be sort of, maybe not in this scenario, but it could be sort of kidney, for example. So that doesn't necessarily move, or it could be a mass that's a very huge liver, for example, that moves on respiration. So that's sort of why we talk about it in that sense. Negative findings is no tremor, no Cushingoid appearance, no gingival hypertrophy. That's because those are the things that you would expect in someone who's had a renal transplant, because that can have a tremor, which can be a secondary to sort of things like cyclosporin. Also, gingival hypertrophy can be caused by tacrolimus as well, and then Cushingoid appearance can be caused by steroids, which people can have. And then in renal, you'd always really want to say previous modes of renal replacement therapy and then current modes. And then in the most common causes of renal failure is always going to be diabetes, hypertension, chronic glomerulonephritis, and then polycystic kidney disease. Those are the most common. And then you talk about investigations, and that really sets you up in a good way to talk about management in more detail. So yeah, I hope that makes sense. This is a bit more about presenting. So I think that's us for today, really. That's sort of a case that we discussed loads of other stuff. Please do send me feedback. I really want to know what you liked about this and what's good and what's bad so that we can improve it. This is all very sort of new format. If it's useful, if it's not useful, let me know. Do you like the slides as well? There's a new color scheme. Again, let me know if you do like that. I hope this was useful. Slightly longer than the one before. Do you want it to be longer? Do you want it to be shorter? Yeah, just let me know. And then if you do like it, then we will do more of these going forward as well. But yeah, thanks very much. And if you have any questions, yeah, please put them on at the moment.
Thank you very much for that, yes. And just to say, I popped a link for the feedback form in the chat so everyone can access it there.
Thank you very much. I'll stop sharing now as well. Thanks, guys. Much appreciated. You're very welcome. I hope it was useful. Yeah, I might do a few more depending on feedback. So if feedback's good, keep doing it. If not, I'll leave it to the other lecturers to keep going and go back to my question writing. So Millie, you said you're in the third year. Was that useful for someone who's just started out clinical medicine, or is that, what do you reckon?
Yeah, it was useful. It's nice to see sort of the end product that we need to aim to be. Some of it was a little bit beyond my understanding at this point, but I really liked when you were presenting back and sort of how to structure it. I thought that was quite useful.
Cool, that's good. I'm thinking of doing some presenting stuff going forward, I think, because I think it causes a lot of anxiety. It definitely caused me loads of anxiety when I was final year. Just don't know what to say. What do you want me to say? You know, it's just very, in a very time-pressured OSCE environment. It's all very stressful.
Yeah, it can be quite overwhelming.
Right. So any other questions at all from anyone, guys? I don't think there is at the moment. Yeah. Cool. Okay, so I think that's me. Yeah, any other questions, just email me. So you can either email me here, I'll put it down there. Sorry, that's my email. QuestMed.com, or do it on Facebook, which is, I think, on Instagram. Whichever one. We all have access to it anyways. Yeah, Facebook or Instagram, which they're on the slides anyways. So cool. Right, yeah, please do fill in the feedback. I really want to know what to do going forward. And then yeah, cool. Okay, thanks a lot, yeah, I'll see you later.
Thank you. See you later.
Bye, take care.